This week on the BackTable podcast.
Yeah, the phrase that I use is no money, no mission, right? So you can want to provide healthcare for all the underserved population you want, but if you don't have a nurse to help you do a surgery or to room your patient or anything like that, then you cannot provide that healthcare. There's a minimum level of money required to provide that care. And so learning how to do all of this coding and billing properly, like you said before, not gaming the system, just playing the game properly and knowing all the rules that are involved. And by doing that, then your department, your practice, wherever you're at, then has the money to be able to provide for the mission, whether that mission is all of our employees are going to get a living wage, or is the mission a certain percentage of our patients are going to be people with no insurance. How are we going to run our office? And that all requires money.
Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman. And once again, I've got one of my good friends and mentors on the show with us tonight. We've got Dr. Jon Hathaway joining us from Indiana. Jon, how are you?
Doing great. How are you?
I'm doing good. It's good to see you.
It's good to see you as well.
Welcome to the show. Dr. Hathaway is an associate professor of OBGYN at the IU School of Medicine in Indianapolis, and he is a coding guru. I mean, if you ever see him and have questions, I've never met anyone who knows as much as he does about this stuff, and this is something that I wouldn't say passion, I think it's overrated, but your curiosity and your in-depth knowledge about this really is something that is just so not just impressive, but helpful to so many. But so thank you for coming on the show today. And as we like to do, we like to have our guests introduce themselves, sort of how you got to be doing what you're doing and how'd you get into all this stuff?
Yeah, so it's an interesting story. I think it's an interesting story. But when I first started at Indiana University, they kept track of every dollar that was collected on our behalf. And then we would get paid based on how many dollars they collected for us. And my department chair at the time said, don't worry about making your salary the first couple of years. That's why you're on a guarantee. But by the end of 2 years, we'll adjust your salary either up or down to match what your revenue is coming in. And so I thought, so I get to control how much money I make. And so I started working and then realizing I'm taking the same number of calls as all my partners who've been here forever. And I'm doing the same amount of resident clinics and same number of deliveries and seeing the same number of patients. Why should I be making less money than everybody else just because I'm new if I'm doing the same amount of work? So I read a couple of coding books and that ACOG produced, and after 6 months had made my entire year's salary. And then they started writing me checks for the next 6 months because I was making above and beyond my salary. So then my department chairman had me audited like 3 times in the first year to make sure I wasn't doing anything fraudulent. And there were some things I didn't understand, but they weren't fraudulent stuff. It was just like, which ICD code do you use for that procedure instead of the one you did use. And so after that year, they said, maybe you should start teaching this stuff. So I started teaching it to my partners, and the national office caught wind and put me on the coding committee. That was in 2007. And the rest is kind of history. I've always just used a lot of my volunteer time to help with coding and billing. And I think that it's something very simple to learn. And I was shocked at how much money we leave on the table just because we don't know how to, I don't want to say play the game, but I'm going to say play the game. We don't know how the rules, the process work. And so because we don't understand the rules, we don't get the full value of what we should be getting.
No, and I love that story because it was really just you following your curiosity, looking out to make sure that things were being done fairly, right? Not looking to gain an edge or gain the system, just like, hey man, let me learn the system. And that was something, and so I met you in DC, and I'm trying to remember the year, probably 2012 or so. When I first started here, I was invited to join Craig Sobolewski. He was AGL's liaison to the ACOG, the Committee for Health Economics and Coding. And I think he was getting tired of doing it. And so AGL said, hey, will you go with him? You're young and you can sort of learn and take over. When I went to that first meeting, I didn't know what it was, first of all. I was like, I got an invitation to a committee. I don't know what this is. And my chair was like, good for your CV, just go. Like, I'm an English major. I don't know, it's not anything I knew about specifically. And I went in the room with you and others, and I felt like I was sitting in another country. I mean, the language you were speaking, what you guys are talking about. And I remember thinking to myself after about 3 or 4 hours, like, wait, that's how this works? That's how this whole business works? I've spent a decade of my life learning to work in an industry that I have no idea how it works financially. There's no, like, this is how all of us get paid. It's mind-blowing to think that none of us are taught. And maybe it's different now. Maybe you teach courses at IU, but I can tell you most of my peers and I have no idea. And so I'd go to these meetings twice a year. And I remember Donna was like, you seem interested, just sit in the room, hang out, and you'll learn after a couple of years. And I was like, a couple of years? But it is a lifelong learning process, like most things. But I remember thinking, I'm the dumbest guy in this room, not because I'm a dumb person, because I'm surrounded by really thoughtful, engaged, talented people. And then I go back to my institution and I was the expert. Like, right. I knew more than anybody because I've been listening to you guys just for a couple of years. So talk a little bit about sort of the information asymmetry, if you will, between what the people in that room know and what the average OBGYN knows after coming out of training. And tell me about what your sense of that is and why you think that's the way it is.
Yeah, I think that we don't do a good job in residency about educating our residents. And I think that that's part of the problem that we experience in our field. I think of my friend who's a dentist, and they took classes on how to run their private dental practice. And that was all part of the curriculum. And we don't have that in OBGYN. And I give grand rounds in our institution every year. It's a 2-hour grand rounds presentation, and the residents, the interns are just looking at you like, oh my goodness, like, I don't understand anything that you're talking about. And the chiefs are looking at you like, okay, I better memorize all this because, in just a few months.
Yeah. What year do they start listening? Like, oh crap, this is coming up.
I think it's third year is when they start saying, okay, I better learn this system. But it's odd because there are no other careers that I can think of where how the money comes in and goes out is not front and center. There's nobody that goes into financial planning that doesn't say, well, what's a stock and what's an equity and how does the bond market work again? Like, they know exactly how that works, and they know exactly how they learn how do we get customers and how do we build those customers and all that stuff. And we know none of that. And I think that sometimes because in our careers, we write all these great essays when we're getting into medical school about how we want to change the world and we're doing this just because we love people and we wanted, and especially in OBGYN, we want women's health and we care about all that. And I'm not saying we don't, but that seems to be the focus. And so then we think that the money side of it is a little bit dirty, like, oh, I don't get involved in the money. I just care about my patient's overall well-being. And
so I want to touch on that because I think there's a bunch of consequences to that. And I agree with you. And I think and I try not to be too cynical about it, but ultimately I think there is an altruism sort of like myth here because it's a business, and the people who decided it was a business 100 years ago was us. So right. Let's not blame anyone else, right? This is not anyone else's fault but our own as physicians. We decided 100 years ago this is a business, and we are going to oppose, and the AMA and others are going to oppose any socialized healthcare. So it's a business, but it feels like the reason I got so into it was not because, oh man, this is how we get paid, right? I realized that it was 17 years from when a paper gets published, landmark paper to when actual like practice changes nationally, to like when it actually gets out. You devalue a procedure, the number of times that procedure gets done in the next 12 months is less, right? It goes down.
Right.
The potential impact on the care we provide is immediate and is real. And that to me was a very powerful sort of like aha moment of like, well, oh, wait a second. Like, I'm not into research, but like, I can impact healthcare outside of my clinic, outside of my ORs. Like, I can really change how we care for folks and figure out how this system works to make it work in our patients' benefit. Because it's designed in a certain way. The system's not broken. I told a med student today. System's doing exactly what it's designed to do, right?
Yeah, the challenges in this market is that the insurance provider is the payer, the patient is the consumer, but doesn't pay directly. And then we are the business providing the service, but we don't get paid directly from the consumer. We get paid from a third party. And so that's where I think this business gets trickier than most other businesses, right? I go to the grocery store, pull something off the shelf, I go to the cashier, I pay them money to take that out of the store. And I say, okay, I'm going to get the store brand because it's cheaper, or I like the taste of the name brand, so I'm going to buy the name brand. Like I'm making decisions on how much money I want to spend based on a lot of other factors. But in healthcare, that's separate. It's disconnected. And so I think that's also part of the challenge, is that the patient is disconnected. I mean, how many times have we had patients show up in the emergency room pregnant saying, I just want an ultrasound? And, you have to say, well, we have to have a reason to do an ultrasound. And some people just don't understand that. Well, what do you mean? You can't just give me an ultrasound because I want one. And so it makes it a challenge. Or I'm tired of having a period, so I just want my uterus out. And you're like, well, that's not how it works, but if it was a consumer paying the bill, like a plastic surgery, it could be that way, right? It could be like, oh, you want your uterus out? Okay, pay $40,000 and here you go. So much like a plastic surgeon.
I was taking one of our courses here and, trying to do like sort of basic, I'm getting my MBA now, but this was like in one of the leadership courses, and they had like, who's the customer and, customer service kind of things. And I was like, they're talking about the patient. And I said, I wonder if maybe that the patient's not the customer. Maybe our insurers are the customers, right? That's who, as a hospital system, we are negotiating with. That is like the ones we have to please, right? Those are the ones that we need to cater to because they're the ones paying us, right? Patients don't pay us. The patients are the customers of the insurance companies. Actually, typically the patient's employers are the customers of the insurance companies, right? So we have to serve the insurance companies. We have to give them good service and make sure they don't pay too much for the care that we're providing. The employers have to choose their insurance company for their employees, right? I mean, that to me is what a customer is. So to me, really, the patients are sort of like the negotiating right. piece of all this, right? They're the ones saying, we've got these patients who wants our business. And the patients really they're consumers, but I don't know that they're customers in this equation in a way that we're used to. Like you said, I mean, I think we're sort of saying the same thing, but in a sense, the patient-physician relationship is a stone being squeezed by everybody else.
Yeah. And are we the business? I don't know that we're even the business, right? Because the insurance company doesn't negotiate with me. They negotiate with Indiana University Health or whoever you work for, and I'm the product, right? They're selling me.
Exactly. Exactly. You are not the business. That's correct. You are not the owner of the business. You are the product that is being farmed out, right? You are again, I'm proud of what we do, but are you the cattle out there pulling the plows or whatever, right? The livestock pulling the plow. And so, I think that's been, especially more recently, it's been a change in that we used to be business owners. Used to own our businesses, but as it's gotten more expensive and the laws have changed and the cost of care, and we now are employees. Again, not good or bad. I don't say it with judgment. It just is the way it is. But the system has resulted in, or rather those changes have resulted in a system in which we are providing a service and everyone else is making money, right? Not like the hospital's got to make money on us. The suppliers who supply our IV tubing and our drapes, the ortho, we could talk all day about ortho supplies and all the disposables there and all the implants. But all of those businesses that are making money on the patient-physician relationship, that's the thing, right? It's like, I'm from Kentucky. We talk about horse racing. When people don't understand, it's not the races that make the money. You race, and then people make money later on the breeding. That's like what you see up front is not the actual business. There's the stuff behind the scenes is where all the money's changing hands.
Right. And that's not including the gambling. It's not the ticket to get into the horse race that they're making money off of. It's the gambling.
Well, now we're talking about private equity in healthcare, right? There's people gambling on the backs of the horses.
Right.
And so I think, coming back to what we're talking about, though, I think the goal of me learning more about this and trying to, get as much information out of folks like you that I can is because the letter I wrote to my med school for my application was from a good place. It was real. I genuinely care about my patients. And I know you as a person and as a doc absolutely care about taking good care of his patients and want to do a good job. but you also know you got to take care of yourself so you can be a good doctor. And you got to have a hospital that can run itself to take care of folks that maybe are under or uninsured, right? So there's all these other pieces. And so how do we understand the system enough in a way to make sure the system works for the people that we're hoping that it's supposed to work for? And so that's sort of what keeps me involved. But I think, it's bigger than just, collecting. But
yeah, the phrase that I use is no money, no mission, right? So you can want to provide healthcare for all the underserved population you want, but if you don't have a nurse to help you do a surgery or to room your patient or anything like that, then you cannot provide that healthcare. So how do you, there's a minimum level of money required to provide that care. And so learning how to do all of this coding and billing properly, again, like you said before, not gaming the system, just playing the game properly and knowing all the rules that are involved. And by doing that, then your department, your practice, wherever you're at, then has the money to be able to provide for the mission, whether that mission is all of our employees are going to get a living wage, or is the mission we're going to provide, care to people who can't, a certain percentage of our patients are going to be people with no insurance. How are we going to run our office? And that all requires money.
And that's absolutely right. I mean, I think I say the same thing all the time. No money, no mission, right? We got to take care of folks that need care, and not all of them can pay. So how do we build a system that allows people to get care? And you mentioned your first job, right? Like you got paid as the collections came in, which is, I don't know how many folks do it these days. I've got some colleagues in other places that are paid on a collections base, which is a little bit, you think about folks coming with little or no insurance. Is that going to impact the care you provide? You can say no, but the reality is it does. Whereas I happen to work in a place where it's RVU-based regardless of collections, right? So there's a bad debt line in the spreadsheet for our institution that covers what we don't get paid for services, but the physician gets paid regardless. There is no disincentive to take care of folks without insurance.
Right.
And I think that's something that most of us feel pretty good about.
Yeah, it definitely removes who the payer is from your decision-making about what care you're going to provide. Now, you may not be able to get an MRI or a CT scan, or, today I called a patient about an abnormal colposcopy and she needs a LEEP. And she's like, I don't have any insurance. And so we're setting her up with a financial counselor so that she can figure out what options are available for her based on where she lives. But yeah, all those things make it a challenge to provide her with that care. But I was able to do the care I did regardless of what her insurance status was.
No, it's nice. And I think if you're someone who's interested in learning this stuff, I think, again, you kind of did it yourself to start and sort of became a very, very local expert and, just in yourself, in your practice. And we're not going to do a whole coding session here, but I think talk to us a little bit about just sort of like the background of, very briefly, CPT, RVUs, and ICD, and sort of what all those are. And I know most people know a little bit, but in terms of like how that is sort of the backbone, sort of the language or the alphabet really for billing and coding.
Yeah, so there's two parts to every bill that gets sent to the insurance company. One is the CPT code, which is what you did. And then the second one is the ICD, which is International Classification Disease. Why did you do it? So if you try to bill a hysterectomy for an ingrown toenail, the insurance company is going to deny that claim, right? Because you don't treat an ingrown toenail with a hysterectomy. So both of those work together, and some bean counter somewhere has come up with a big spreadsheet that says, if you bill code X, then you must have reason Y for the bill. And if it's not reason Y, then we're just going to deny the claim. And nobody even sees that. No human even sees that. It just gets automatically filtered out. Hopefully your hospital system or whoever does your billing for you has what they call them claim scrubbers, that goes through and already picks that out and says, hey, I think this is the wrong code. Do you want to put a different code in? And then you can put a different code in before it ever gets sent to the insurance company and then denied, and then someone has to look at it. So most of the time, most big, larger systems have those claim scrubbers. So what you did and then why you did it. Now, every CPT code, every procedure, everything that you do has a value assigned to it. And Congress mandated that must be based on the time that it takes to do the procedure and the intensity to do the procedure. So an emergency intubation might only take a short amount of time, but super intense if you can't find the airway, or some other like CPR or something like that. It may not take a long time, but it's intense versus, something else where you're going to put a Band-Aid on something. It's not only does it not take a lot of time, but it's also not very intense. And so those two things are factored into the value to every code. On top of that is not just the physician work, but also how much does it cost to provide that care. So for example, there's now a code that you can use if you're not in a hospital, if you're in your own private office, to cover the cost of a speculum and to cover the cost of the nurse that chaperones your visit and swabs and drape and all those things that you may not need if you're not doing a pelvic exam. And so there's a code for that. And that has been valued based on all of those things, the practice expense. It doesn't give the physician any work units value, but it has your practice expense value.
And that's the difference between the work RVU.
Right. And the practice expense RVU, which is separate from the work RVU. And then on top of that, there's what's called the liability expense, which is how much does it cost to have malpractice for that type of procedure. So you do a pap smear, probably not going to get sued for doing a pap smear. And so the malpractice cost might be very, very low. But you're doing open heart surgery on someone, or you're doing a hysterectomy on someone, the likelihood of getting sued, or delivering a baby, the likelihood of getting sued might be higher. And so they factor that into the RVUs as well. So then what the practice sees is the work RVUs, the practice expense RVUs, and then the liability RVUs. So all three of those are factored into the total number of RVUs that are valued. And I think sometimes people look in a book or a table or something and they get confused about what's the practice RVU or what's the total RVUs and what's the work RVUs. And then also they think, well, I'm doing this in a hospital. Why are the RVUs less than if I'm doing this in my office? And it's because the hospital bills separately for all the equipment and tools that you use versus if you're doing it in the office, you have to buy all those things. And so that also factors into such. And so I do get questions about, well, why if I do hysteroscopy in my office, do I get this many RVUs? And if I do it in the hospital, I get much, much less RVUs, fewer RVUs. And the answer is, well, because you had to buy the scope and to do it in your office, and you had to
And the
use
work
the room.
RVUs are not different.
Right. The work RVUs are identical. It's just the total RVUs.
It's the practice expense RVU.
Yeah,
and the last is what, a geographic component, right? That it's more expensive to do in New York versus Kentucky, but not
right. It's
the
just
coefficient.
you have to pay your staff and rent your space and all that stuff. And that costs more in certain parts of the country than other parts of the country. Those are a little bit political. They're set by Medicare. And so if you have good representation from your member of Congress, you might get more of a geographical expense. It's not just
by state?
It's by region, actually, in state. So
I guess Lexington versus a rural area versus, I could see that.
you can look all that stuff up and see what it is. But if you are in a place like California, where it costs a lot more to hire somebody versus a place like Texas or Kentucky, where it's less money to hire people to work for you, then you're going to get less of that geographical adjustment. But that's just for Medicare. I don't think that's for the private insurers.
So who oversees CPT? So CPT is sort of, and I described this like a bill becoming a law, right?
Right.
We've sat through enough of these meetings
Exactly
together.
right.
Anyone can propose a new procedure, but for it to become a level 1 code, for a bill to become a law, it takes a lot of, talk us through the process, because it's administrative, but it's also a little bit political, right?
Yeah, right. So there's the committee that decides all this stuff. So CPT is actually privately owned by the American Medical Association. So sometimes if you try to Google a procedure code, you're not going to find the answer because that's privately owned, versus the International Classification of Disease, which is not privately owned. So that's easily Googleable, and there's plenty of websites out there that will tell you ICD codes, but there are very few that will tell you CPT codes, and even fewer.
At least without a paywall, right?
Right, exactly. And even fewer that will tell you the work RVUs associated with a procedure. And that's because they have to pay the AMA for access to the database. So they're just passing along that cost to their customer, which is you. So the CPT is owned by the American Medical Association, and their committee meets 3 times a year, and anybody can propose a procedure in anything. You can propose a procedure for picking lint out of your belly button, right? Like that could be a procedure. We'd probably call it removal of foreign body from umbilicus, but it's still the same sort of thing. And anyone can propose that, and then the committee votes on to whether that's a valid procedure or not. Now, it has to be practiced by a significant number of physicians or healthcare providers in the United States. You have to have US-based literature showing that it's a valid procedure and benefits patients. So you can't just randomly come up with something that you say, oh,
Is it
yeah.
3 out of 5 or 2 out of 5? What's the number? I'm trying to remember.
You definitely have to have 5 articles that are all US-based.
I think, 2 or 3 have to be, they're all US-based.
Yeah, they all have to be US-based.
Some percentages of this.
Oh, don't quote me on that. I'm actually not on the CPT committee side of things. So,
have you ever been or no?
No, I tried it out once, and I was more interested in the RVU side than I was in the making of the code side. But I would say most codes that get presented to the AMA don't get approved. Just because for one reason or another, there's not enough data, there's not enough doctors that do it. It's not been shown to be useful. Those are all things that get factored into whether a procedure becomes a code. Now, some procedures get what's called a Category 3 code, which is a research-based, and then that way they can start using it for tracking. Those don't get valued in the system with everybody else, but they do get used for tracking. And so then they can say, oh, look, we have 75 doctors that are doing this at 50 different sites across the country. They're doing research showing that it's a valid procedure. Maybe we should apply to become a Category 1 code.
And that's common with newer procedures, newer technologies.
Right.
And they do it, and in some cases, they'll get insurance companies to value it. And that's less common, but certain payers will pay before CMS will pay for it, before it's made into a level 1 code and before it's valued, but that's pretty infrequent, right?
I think a lot of codes go through that process, actually. So like the endometrial ablation code went through that process with the ThermaChoice, if you remember the old ThermaChoice balloons.
Yeah.
But then when newer techniques came out with newer devices that were still the same process, essentially, of ablating the endometrium, then those just piggybacked on to the endometrial ablation code. But it was originally valued to take 60 minutes because ThermaChoice did take longer to do. But then when these newer devices came out, the CMS said, I think we need to revalue this because it was a new procedure, and now I think you guys are better at it. And so then we revalued it, we resurveyed doctors, and sure enough, instead of taking 60 minutes, it now only took 30 minutes. And so they cut the value quite a bit because they said, look, it doesn't take as long as we originally thought anymore. And so now it's valued less because it takes you less time.
And so once a CPT code is official, like it passes, and there's some politics there too, right? Because if you have a new code, if it's similar to any other codes, they kind of open up all the old codes and revalue them all, and that can change RVU values, which may be worse than what you had. So it gets very political having to have ACOG and others kind of like partner with you in this. And ACOG was very supportive of reasonable things, but it can make it more challenging sometimes to get codes approved or make it more onerous.
Right. So there was a new set of codes out for cysts in the abdomen, whether they were endometriomas or peritoneal cysts in abdomen and pelvis. And the challenge with that code set was that not only did it take away from the previous code set, but it also involved having general surgery involved, because they also do things. And so the American College of Surgeons and American College of OBGYNs had to get together to agree on stuff. And we agreed on that we needed to revalue those codes because things were different than they were when they originally made. The problem that comes in is when one of the other specialties says, no, we're happy with the way things are. And then our specialty or our specialty says we're happy. Either way, one specialty says they're happy and the other specialty says we're not happy. Then that's where the politics can come into play, where we say, well, we want to change this up. And the other specialties that do that same procedure say, well, we don't want you to change that up. So we're not going to support your application to change things up. And also, there is a rule that you cannot just isolate one code. So if you want to revalue the hysterectomy codes, you have to revalue all the hysterectomy codes. You can't just pick one hysterectomy code and revalue it. Well, we want to revalue the hysterectomy with tubes over 250 grams. Okay, well, you got to revalue all the laparoscopic hysterectomy codes, the under 250, the over 250, with tubes, without tubes, with ovaries, without ovaries. You got to revalue all those. You can't just randomly pick one code.
And what's the reason in that? Because it's federal law, right?
Yeah, it's federal law because it has to be budget neutral. And so
That's right.
You can't collect more money than you're allowed. The pie is a certain fixed space. And so if you want a bigger piece of the pie, then somewhere's got to take a smaller piece of the pie. And that's all mandated by Congress. That's not the AMA who picks that. That's just what Congress tells us.
And what do they say at the check every year, 1,000 times? Some are easy, some are hard, right? So
right.
It's valued at the 50th percentile. So if you do that big, giant, long case and you're like, man, they don't pay me enough. This is too hard. I've never heard anyone say in a really easy case, man, that was too easy.
I should get less.
I'm going to give some money back.
Right. Nobody ever says that.
So I think that's the thing we have to remind each other. But once a level 1 CPT code is assigned to a procedure and the committee votes and says, yep, we agree, then what happens?
Then it has to get valued. So I think it's no secret. There's definitely been public hearings that ACOG is reworking the obstetrical codes, labor and all that stuff, because the days of you showing up at your doctor's office, them seeing you for 13 visits, and then you deliver, and the doctor who you saw for all 13 of those visits is the same doctor who's delivering you, who's rounding on you in the hospital afterwards and sees you for your postpartum visit. I think those days are pretty much gone. So there's been some public hearings on all of that. So how that works then is once the CPT committee says, yep, we approved all of this, this is how it goes, then the next step is a survey. So then the member societies all get together and come up with a survey that has to follow the guidelines that are set up by Congress, which is time and intensity. How much time does it take? How intense is it? And then compare that to other codes that are already valued. So you're anchored by everything that's already been valued. And then send out that survey to everybody. And then everybody puts in how long it takes them. Is this more or less intense than these other procedures that are already valued? And then how many RVUs do you think this should be worth? And then you put all that information in. And then again, some bean counter who we love calculates up all that stuff and says, okay, here's the mean, here's the 25th percentile, here's how much time people said it took, here's all the visits that are involved in that procedure. And then we present that to the Relative Value-Based Update Committee, or we call it the RUC for short. And then they vote and they say, okay, the specialty societies who do this procedure have this data, and so they think it should be worth this many RVUs. And then they vote yes or no. And if it's no, then we have to revisit. And they say, well, then what do you think it should be worth? And then these people around the committee say, well, I think this procedure is like that procedure, and I think it should be worth about the same amount as that procedure is worth. And so then that value gets adjusted up or down, usually down. Let's be clear, it's usually down based on what the other codes that everybody else thinks are similar to it so are valued at. So a classic example of this was when they decided that one of the things that one of our membership wanted was a cystoscopy included in the laparoscopic hysterectomy codes and the vaginal hysterectomy codes too. And so then they added the word cystoscopy to the CPT descriptor for the procedure. So when they added that number or added that word to the descriptor, then it triggered an automatic survey. Okay, well, if we're adding something to this code, then we need to survey. And so we sent out surveys to the membership and said, how long does it take you? Now there's a cystoscopy involved. How long does it take to do it? It was identical. There was no difference in how many minutes our membership said it took to do a hysterectomy with a cystoscopy and without a cystoscopy. So because there was no difference, there was no change in the value of the procedure. But now it includes cystoscopy.
And now we've seen where when a new procedure comes like TLH, right? And then 6 months later you do, was it 6 months or a year? How long, what's the audit time and the resurvey time? How many, is it years? I can't remember.
It's 2 to 3 years.
After a new code.
Yeah, 2 to 3 years.
Yeah, 2 to 3 years. And then they resurvey and like, oh, we're a lot faster. And you're like, no, don't say we're faster. Because then they adjust the value down.
Right. And people put in their world records fastest hysterectomy, and it's like, wait, don't do that.
That's not helpful.
Think about some are easy and some are hard, and give us a average value of
And how many
those
total
codes.
surveys are we getting back here? Because I remember the number being like shockingly low.
It's super low. So on average, I think we have between 50 and 100 doctors will fill out the surveys from sending it out to 5 to 10,000 people. So we're looking at about one, I don't know that I've seen too many surveys that are from OBGYNs that are over 2% of the people who get the survey in their mailbox, in email box, about 1 to 2% will fill out those surveys at the most. And yet
this is what
the other
determines what we get paid.
98%, right? So yeah, and those surveys come from me actually. So it's my name on it. It comes from ACOG's website, so it'll be acog.org. And then, but the signature at the bottom will be my name right now because I'm the one that is in that position.
What's your role at ACOG right now?
I'm the advisor to the RUC committee. So when there's an OBGYN code, these 31 doctors all have to vote on what the value is. And so essentially, they're asking me to give them advice on how long it takes, how many RVUs it should be worth, and where do I get that information from? From these surveys. And so I say, well, when we asked our membership, how long does it take? How intense is it? What other codes are already valued that it's like? This is what they're telling me. And that's the data that they use to make their decision. So I'm just the advisor. I don't actually get to vote on these things, but I'm the one that presents that information to this committee.
And do we have a voting member? OBGYNs have a voting member on the committee?
Yeah,
still?
we do have one voting member on that committee.
And how long have you been in your role?
Oh my goodness. Let me try and think. Probably 11 years now, I think, 10, 11 years I've been doing this.
I know that I'd been to one, I'm sure you were there, trying to get some more people involved, like as a backup. But it was like, I went to a couple CPT meetings and I went to a rep meeting and I said, okay, I think I was going to 8 meetings between the 2 check meetings, CPT and a RUC, and I was going to AGL and I was going to APCO because I was a clerkship director. I think I went to like 8 meetings when you're at most. I said, I hated to say it because I'd done it for maybe 5 or 6 years, but I had to pick. I had to go somewhere else.
Yeah,
So
I'm the associate clerkship director too for our clerkship. So I probably spend 30 days a year at meetings.
Well, no, and that's what I was trying to get to was your time commitment. Is massive, right? So is this all vacation time? Are you given professional time within your department? Because you're making everybody look good by doing what you're doing and being a nationally recognized, internationally recognized expert on this stuff. Like, are you getting the opportunity to do it without too much of a hit?
Yeah, I'm taking a hit because we're RVU-based. So every day I'm out of the office is a day I'm not making RVUs. So, but Indiana University is super generous. I'm really grateful that my boss allows me to take as much time as I need, as long as I'm making my salary with my RVUs, then I can do this sort of thing. And then one of the benefits about being an RVU expert is I know how to maximize what we're doing. And so I don't see a hit in my salary, but I imagine that if I wasn't doing all of this, I would see a bump in my income.
Right. Whether it's bonuses or base or, there's certainly, you make more overviews. I don't know, I won't ask you or about IU specifically, but most places these days have some productivity component to their salaries. And so it's going back to that altruism piece of it, right? Like
ours is totally RVU based.
Eat what you kill on RVUs, dollar per RVU based on
100%.
Yeah.
And the last RVU you make on December 31st is valued the same as the RVU you make on January 1st. There's no like scaling of the RVUs. It's the same the whole year. And then at the end of the year, somebody like does a reconciliation, says every 2 weeks you got a paycheck because we thought you would build this many RVUs this year, and you build more than that. Here's the extra.
Here's a bonus.
Yeah, here's your bonus. Or you build less than that. Write us a check for this amount.
Really? Write us a check?
I've heard of some of my partners having to write checks. I have never had to write a check. So I'm conservative. I like getting the bonus at the end of the year. I do not want to write a check. So
it's amazing how different every institution does it. It's amazing how everyone thinks they've figured it out. And that's, my econ class, in accounting right now, the incentives of collections-based, RVU-based or productivity-based versus base salary, no bonus versus, talking to John Solnick on this show about everything you do in the Canadian system is cost because we get one check as a hospital system. And so there's all these different ways to do it and how physicians or patients or systems can benefit or otherwise based on how it's all set up. But it all comes from this, right? This is why understanding this stuff is so key.
Yeah. And I think there's two other important points about this. One is that because our university values innovation, if a surgeon or a doctor of any sort does an innovative procedure that has no RVU value, we have a committee that actually most of us also work with the RUC a lot nationally, who sit down and look at the operative note, look at how long it took, and come up with an RVU value for that.
So like your own internal RUC.
Yeah,
in a sense.
Essentially it's our own internal RUC.
Interesting.
So that we can value innovative techniques and procedures. And there are some rules about that. Like we're not worried about, is it a procedure that's valued by the CPT codes? These are mostly the unlisted procedure codes. If it's an optional surgery. So for example, we don't value any of the cash paying plastic surgery stuff. And we don't value any of the cash paying infertility stuff. That's not our job. Our job is to say the hospital is billing insurance carrier base, like your patient came in and had this major surgery done and we billed you X amount of dollars and you paid us Y amount of dollars and the surgeon got nothing. We want to value the surgeon's efforts. And so when that happens, then we do it. But if the insurance isn't paying for it because it's not a covered service or something like that, then we don't value those procedures. So that's number one. The second one is that I am shocked at how many institutions pay the dollars per RVU based on specialty. So I know of institutions where some specialties like orthopedics get twice as many dollars per RVU than OBGYN or primary care.
Isn't that the norm?
I think so, but even though Medicare doesn't, like an RVU for an ortho procedure is the same as an RVU for OBGYN, is the same as an RVU for urology, but the dollars per RVU are what messes with things. And it's because OBGYN does so much government work. We deliver so many babies on Medicaid and we do so much Medicare work that our percentage of patients who are private payer are lower. And so when the hospital system says, well, here's how many RVUs we billed for your whole department last year, and here's how many dollars we got from your whole department last year, so here's your dollars per RVU, and that's what we're going to pay you based on. If you have a lot of private payers in your system, you're going to get paid better than if you don't, which is why urology, who takes care of mostly 40 to 60-year-old men, right? That's their number one clientele, who most of them have jobs, who most of them have private insurance and get paid the higher dollars per RVU from those private insurance companies. Now they're getting more dollars per RVU in their health system than OBGYN is. And nothing makes that more obvious than in the urogynecologist versus the urologist who do female incontinence. And because their department gets paid more per RVU than ours. It's not that the RVUs are different. I know there's a lot of public press and like, oh, the RVUs are off. No, cystoscopy gets paid. There's the same number of RVUs for cystoscopy, whether it's done by me or whether it's done by my colleagues in urology, or whether it's done by my primary care family practice doc who happens to do cystoscopies in the office for whatever reason. Like the work RVUs are the exact same. It's what your system does.
Right. And that's something that I've talked about a bit, which is that it's a double valuation, right? So the RUC was supposed to value the procedures based on difficulty, time, intensity, but then we're now using some other multiplier on top of that. You have markets though, right? So at some point you have to recruit people. And so if an OBGYN generalist is easier to recruit than a GYN oncologist or a urogynecologist, a laparoscopic hysterectomy is going to be valued the same, but it's going to get paid differently. So a GYN oncologist on call doing an ectopic is going to get paid more than a generalist on call doing an ectopic. Not saying it's the right system, but that's how a lot of hospitals have it set up when they have, because MGMA and all these companies have, dollar per RVU coefficients for subspecialties, right? I mean, all the different specialties, they have that. It's all
data.
That's what most places are doing.
Yeah. We could
right?
call it money GYN instead
place?
of money ball. Yeah. Call it money GYN. Yeah.
And that, or money medicine. I mean, it's every specialty has a dollar per RVU based on your specialty on top of what they've already decided is the value of that procedure. And so that's something that, it's how much do you need that person and how many of them are there out there? That's supply and demand. Like CMS may have valued it, but we're in Kentucky. Maybe it's harder to recruit to Kentucky than it is to places like Chicago or New York where there's more people and maybe more people want to live versus somewhere that's less, Eastern Kentucky, they got to pay folks a lot more than even Lexington. Lexington's a nice city. Eastern Kentucky is a nice place to be, but if you're not from there, it's it can be harder to get people to go out there.
Right.
So yeah, I mean, it's still a market. And so that's where I think a lot of that stuff comes from. But at IU, is everybody getting paid the same dollar per RVU regardless of specialty?
No. Oh no. IU does the same thing. Yeah.
I was going to say, I mean, I can't imagine anyone's not.
Right.
You said it always surprises you how many do, but I would be shocked if any system wasn't doing it.
Yeah, that's probably true. Maybe I shouldn't be so shocked about that. So yeah, when we look at data, for the number of RVUs per minute of OR time, and whether you spread that across specialties, or if you even limit it to we're just going to look at laparoscopic abdominal procedures done by general surgery, by urology, by OB, actually OBs get slightly more or the same number of RVUs per minute of OR time.
Is that OB or GYN or both?
GYN. I'm sorry. We excluded OB because OB is a little bit odd, right? Like how do you value when they have all these 1 year globals, right? Where you see the patient and do a C-section and then postpartum visit, and then you put in the bill. It's a whole year after you started providing the service that you're just getting paid for it. So yeah, when we look at GYN surgery on the pelvis, urology surgery on the pelvis, general surgery on the abdomen and pelvis, the RVUs per minute of OR time are either not statistically different, or in cases where there were statistical differences based on how long the procedure took and things like that, we were getting more RVUs per minute of time.
But so the difference is the dollars per RVU.
100%. It has to be how many, where's our private payers coming from? Not our private payers, but how much are the payers giving us per RVU?
General surgeons' dollar per RVUs, I don't think are as high as some of the GYN specialties, according to the MGA numbers, without getting into specific places, but
right, because they do older people who are on Medicare, but they're still higher than us because they still see men who have careers with private insurance. And while we see women with careers with private insurance, our numbers of patients with private insurance are lower. I mean, half of all babies are born on Medicaid. So,
but for GYN, is it inherently different than urology? Because OB almost seems better than GYN in terms of reimbursement. You can, delivering babies versus GYN surgeons, it seems like there's more money to be made in OB. I've been out of the OB game for a while.
Yeah, so there's more. So at least for Indiana Medicaid pays about the same for a hysterectomy versus delivering a baby. Because we're a la carte. So our Medicaid, you deliver the baby, you get paid for delivering the baby. And then all the prenatal care is separate and the postpartum care is separate. So the dollars, if you look at the Medicaid fee schedule for Indiana, the dollars are very similar for a hysterectomy and delivering a baby. What's the difference? Well, I was on call last night. We delivered 6 babies. But most gynecologists don't do 6 hysterectomies in a single day.
And the residents don't do them, and you're not,
Right. And while the residents make my work less on labor and delivery floor, they make my work more in the GYN surgery floor, right? And so,
yes.
And so that's also part of it. And there's no value for resident. There's no resident modifier, right? There should be a resident modifier. There isn't one. Yeah. So that's the difference between OB versus GYN is I can deliver more babies at different hours than I can do GYN surgery.
Well, we've got about 5 minutes left. And again, I feel like you and I know you could go for hours because you do, but I want to get into your head a little bit about like, what's the way we should be doing it, right? And not to say that your institution or mine's doing it wrong. There's a million ways to do it, but you've been in this space long enough. Is there this like, man, if I was in charge, I would do it this way? And how would you do it? And you can go as big, again, talking to Jon about Canada and other folks about their institutions. Like, what's a way that makes the most sense to you without disparaging any other systems and all those things? We like who we work for. We like our jobs. But like, what is the Jon Hathaway Medical Center doing if you're hiring docs? What's the system?
Yeah, I would love to see a system set up where, I would love to see a national healthcare system. And then your employer can hire, can pay for supplemental insurance that gets you in line faster or pays more to the doctor. So the doctor's more likely to see you quicker or get your surgery quicker or whatever, which eliminates some of the problems in these other national health services, countries where you'll wait 6 months to 8 months to get your surgery. If you have private insurance, then you can get your surgery faster. It's no different than what's currently out there, except it's a little more equitable for those people who don't have insurance. They can get basic life-saving care and not have to worry about getting cervical cancer like this patient that I have.
Preventative care, right, exactly. Because that's how Israel does it. Most of those actually docs have two jobs. They have a public job and a private job, and almost everybody does both.
Yeah.
Bismarck, is that in Germany? Is that how they do it there too? I feel like Australia, Japan have similar, there's like a basic model of care that everybody gets, but if you want to, pay for a premium,
right?
Like you said, it's like a fast pass at Disney World. You get skip lines a little bit,
right? And whether that's fair or not, I'm not here to argue that. I'm just saying that would allow us to continue our current system, but expand coverage for everybody. And I think it would also actually make things better because then you're not tied to a crappy job that you hate just because it has health insurance. So, and I think a lot of Americans are stuck like that.
Yeah, the cuff to their jobs.
Yeah.
Do you think, there's so many hands in the pot now, right? Whether it's with the insurers and all the different, again, you talked about having scrubbers and you talked about having auditors, like the number of people it takes just for a hospital system to get a check from an insurance company for the work that I do for a patient. That work alone is intense enough, right? But the number of people whose hands touch this process, this encounter from beginning to end on both sides of that, the hospital system and the insurance system and everywhere and all the other pieces of it, and suppliers, there's so many pieces of it. And healthcare is complex. We're not going to simplify it too much, but is there enough extra in the system that could almost pay for the system itself?
Yeah, I think there is. I think that actually it can be simplified, right? No one complained about all the livery stables and the wagon wheel makers and the people who shoveled manure out of the streets and all that stuff when the car came along, right? There was a little bit of an adjustment period, but the people who, fed the horses and washed them and whatever, I've never owned a horse. I don't know what they
Sounds
take.
Right. Yeah, let's go with it.
So, I have farmers in my family, so they know horses, but I don't know horses. Anyway, all those people were probably out of a job for a while and they had to learn how to do things differently, but nobody sits back and goes, well, we should definitely go back to, well, maybe there are some people who'd like to go back to the horse and buggy days, but nobody is saying that, right? And, when electricity came out, the candle makers and the whale oil refiners and all that stuff also lost out on their jobs, right? But nobody sits back now and says, well, we should definitely go back to the kerosene lamp in our homes.
Well, that's like the guys who have the signs that say, get your government out of my Medicaid. And it's like, I'm not sure you understand how this,
right.
this system works. But yeah, the idea of taking those things away now would be brutal. But then again, the ACA right now, thinking about how much it impacted people, not their health care, but the first 7 years, the rate of personal bankruptcy filing went down by 50%.
Yeah.
In the first 7 years of the ACA. World changing for people, right? Single biggest reason people file for bankruptcy is medical debt.
Yeah.
Medical
Right.
costs. So
there will be some winners and there will be some losers in the Hathaway healthcare system. But I think that once things get going, nobody will say, "Oh, I wish we could go back to having to get things pre-approved and prior authorizations and all that." No one will go back to that. The problem is getting the lobbies out of the way on that one. So that's one thing. So
a lot of money changing hands in DC, that's for sure.
so I like that dream part, but I'm also a pragmatist. So what's the practical thing we can do? We can do a better job at billing what we're doing today. And when we look at, ACOG has some data, it's older data, but the average doctor who understands coding bills 30% more than the doctor who doesn't.
Does having coders in your hospital and UR and CDI folks, does that offset that at all?
I don't know the
like
answer to that question. Yeah.
I'm curious to see. In the hospital systems, right there, like they got, like you said, scrubbers. They got folks going through and trying to clean up some of our messes.
But I think most of the time they don't clean up your office mess. They just clean up your hospital mess. So me seeing patients in the office, that's where I can have the most impact. And the differences are striking. You know, if you saw a $50 bill on the ground, you'd probably stop and pick it up. But yet we leave $50 bills laying around the office all the time when we don't bill appropriately. So the way I think about it, and I'll just put in my last plug for how to bill for an office visit, because that's where you can make the biggest difference, right? You can't do more hysterectomies than you're doing. You can't make a uterus more than 250 grams if you want, you know, it is what it is as far as the OR goes. But in the office, it's very different. And people who bill well get paid more than people who don't bill well. So the way I look at it is the level 2 visits, whether it's a new patient or an established patient, that's someone who probably should have just asked their mom, "Hey mom, can I ask you a question? I've got this thing going on." And mom will tell you the right answer, because those are people who just need in the official AMA book, they just need a Band-Aid or an ACE wrap or ice.
And those folks are probably not coming to our office much at all. I mean, honestly.
Right. They
not
shouldn't
many
be.
level 2 visits.
Right. Hopefully that's not happening very often. Level 3 visit is something that doesn't need your special expertise. So any doctor anywhere could be like, "Oh yeah, you should put some pressure on that to stop the bleeding and then put a Band-Aid on it." You know, I mean, that's kind of the way I look at the level 3 visit. Again, 99203 or 99213 it doesn't require the specialist care. Yeah. The level 4 visit, that's right in our wheelhouse. Perfect. I'm glad you came to see me for that birth control, for that abnormal uterine bleeding, for that chlamydia infection, that infertility, like whatever, like perfect. I'm so glad you're here to see me. I can take care of you. It's right in my wheelhouse. It's a specialist in another field is not going to know how to manage this as well as I do.
I'm definitely underutilizing my level 4s then.
Yeah, most stuff we do should be level 4. The majority of your bills should be level 4. And then level 5 is that patient that you're like, "Oh man, how did they get on my schedule?" You know, or where's the gynonc? This is definitely in their field house. Or where's the urogynecologist? This person has stage 4 prolapse with who knows what's going on everywhere on the inside. They really need a subspecialist to take care of them. But yet they're here in my office today, so I'm going to do the best I can do and get things sorted out and get them on the right path to get this taken care of. It's above my level of ability, but I know who to send them to. And that's going to be your level 5. That's your pelvic pain patients. That's your ectopic pregnancies. Those are going to be a little more rare, but not uncommon. And if you look at the difference in work RVUs for those different visits, $50 to $100, depending on how many RVUs you're getting, or dollars per RVU, every single one of those patients. And so if you even bump 3 of your patients in a half session of your 12 to 15 that you see up to a level 4, you're going to get an extra roughly 2 to 3 RVUs per half session.
What's RVU difference 3 to 4? Level 3 to level 4, new?
New patient is an entire RVU. If I remember right, it's like 0.91 or something like that. So that's a significant amount. And if you multiply that by how many days you're in the office, every day, every year, we're talking, $50,000 to $100,000, depending on how busy you are, that you could get more of.
Well, everybody needs to go see your coding lectures or invite you to give grand rounds to their institution. I mean, you are a bargain to say the
Right.
least, for any institution to get you down to, to talk to your folks and, follow them around in clinic and show them what they're doing. Because there's just so much we just don't know how to do well. And the number of folks that institutions don't know this stuff. So it's always such a pleasure to get to chat with you. Jon, I think I've got like another 100 questions to ask you, but we'll
send them in an email. I'll get them.
a little late in a Monday, but I'm excited that you and I get to see each other in Vancouver, and you'll have to clean out my PowerPoint to make sure I'm not saying anything wrong, because you're definitely my chat GPT is Jon Hathaway for how to give a good coding talk. So I look forward to seeing you then. It's always a pleasure to catch up with you, and thanks so much for spending time with us tonight.
Yeah, my pleasure.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Orgoginski.
Show notes and social media by Emma Landonwich
and Lindsay Beecham. Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.